Welcome to the Ventilator and Pulmonary Mechanics Chalk Talk series, where we're learning how ventilators work and how to work with ventilators. I'm John McManigal. Let's get started. This time, we're really going to dive into how to use a ventilator, with a focus on ventilation. We saw in Talk 7 that alveolar partial pressure of carbon dioxide, which relates closely to arterial partial pressure of carbon dioxide, is inversely proportional to the alveolar ventilation. So in order to correct hypercarbia, we need to increase minute ventilation by increasing respiratory rate and/or increasing tidal volume. Now, we're really going to focus on the nuts and bolts of ventilator settings, looking at techniques, trade-offs, and complications of increasing ventilation. We'll use volume control and pressure control modes to demonstrate these strategies and to point out some of the practical differences between these modes, but these general principles apply to any conventional ventilator mode. The pressure and flow time graphs on the left side of the screen represent our patient at baseline. Our patient is in volume control mode with a tidal volume of 400 milliliters and a respiratory rate of 12 breaths per minute, which means the respiratory cycle time is 5 seconds. The minute ventilation is the product of the respiratory rate and the tidal volume, which is 4.8 liters per minute, and this patient's inspiratory to expiratory time ratio is 1 to 1.5, so the inspiratory time is 2 seconds and the expiratory time is 3 seconds. Unlike most of the graphs in the Chalk Talks up to this point, I'm going to try to draw these graphs somewhat to scale. So you can see the 4 boxes under the inspiratory flow curve corresponds with a tidal volume of 400 milliliters. The inspiratory time is 2 seconds, represented by 2 small boxes, and even though I'm not going to label the pressures, I'm going to try to keep the pressure curves comparatively to scale as well. To set the stage, let's say this patient is an otherwise healthy adult in their 40s who came in after a car accident. Unfortunately, the airbag failed to deploy and they smashed their face on the steering wheel. They had a CT scan and it doesn't look like there's any intracranial pathology, but they were intubated in the emergency department for airway protection because there are significant face and jaw injuries. So the lungs are healthy, the brain is healthy, but the patient is paralyzed, sedated, and intubated because of the risk of bleeding into the airway. About half an hour after the patient is intubated, you get an arterial blood gas, which shows that the arterial carbon dioxide partial pressure is 60 millimeters of mercury, and you would much rather it be down to the normal value of 40 millimeters of mercury. So how do we achieve that? Strategy number 1 is to increase the respiratory rate. So the next question is, how much do you need to increase the respiratory rate? Well, if your current PaCO2 is 60 millimeters of mercury, and you want to take it down to 2/3 of that value, which is 40 millimeters of mercury, you will have to increase the respiratory rate by the inverse of 2/3, which is 3/2. So if our respiratory rate is currently 12, our new respiratory rate is going to be 18 breaths per minute. So what do the rest of our ventilator parameters look like when we make that change? If the respiratory rate is 18 breaths per minute, and the tidal volume stays unchanged at 400 milliliters, our new minute ventilation will be the product of those, which is 7.2 liters per minute. We're going to go ahead and assume that this is a ventilator where we set the I/E ratio, so that ratio will not change. It's still 1 to 1.5. But because our respiratory rate has increased to 18 breaths per minute, the respiratory cycle time has decreased to 3 1/3 seconds. So at an I/E ratio of 1 to 1.5, the inspiratory time will be 1 1/3 second, and the expiratory time will be 2 seconds. And those changes are purely a result of increasing the respiratory rate with a fixed I/E ratio. So how does this look on the graphs? Let's start by drawing out the timing on the horizontal axis of the volume flow graph. We'll march out an inspiratory time of 1 1/3 seconds, an expiratory time of 2 seconds, and continue on with the next breath and the next. Next, we need to think about the flows. The area under the volume flow curve is the tidal volume, and that tidal volume is set at 400 milliliters. So that area has to remain constant. That means that the flow rate will increase by the same proportion that the inspiratory time decreased. Now, let's draw out the pressure curve. Assume we're starting with an airway pressure here at PEEP. Because our flow rate is 150% of what our original flow rate was, the little delta required to overcome airway resistance is about 150% higher. We're not putting units on pressure for right now, and 150% of a very small pressure step up is still a very small pressure step up, but it is a change. What about pulmonary pressure, which we drew in the dashed blue line? The pulmonary pressure relates to tidal volume by compliance, and the patient's compliance hasn't changed. So if the total volume in the lung is still linearly increasing by a tidal volume of 400 milliliters, the pulmonary pressure still is going to increase in a linear manner to the same pressure. It will just do so at a steeper slope because of the shorter inspiratory time. Our circuit pressure will remain the same delta above the pulmonary pressure to continue to drive constant flow inspiration. When we cycle to expiration, the circuit pressure will return to PEEP as the expiratory valve opens. But how does expiration behave in terms of pulmonary pressure and expiratory flow? This is deceptively easy to figure out. At the end of inspiration, the lung is in exactly the same state after our inspiratory rate change as the lung was in at the end of inspiration before our respiratory rate change. It's the same lung with the same compliance and resistance. The lung is still distended with a 400 milliliter tidal volume, and the circuit pressure is still at PEEP. So the pulmonary pressure will decrease on the right-hand side of the screen at exactly the same rate as it did on the left-hand side of the screen, and the flow will also be identical. We'll draw this out as best we can. And now we start to see a problem. We reach the end of our expiratory time, the ventilator is about to trigger the next breath, and we haven't completed expiration. And you probably remember from Lecture 2 that this will result in auto-PEEP. So this is our first complication or trade-off when it comes to increasing ventilation, auto-PEEP. The reason for this is that the ventilator is ready to start its next inhalation, so we begin our flow-limited volume control breath. Circuit pressure will again rise to a constant delta above pulmonary pressure, and we wind up in a situation where, because our pulmonary pressure and pulmonary volume never quite return to baseline, the peak pressure is going to increase a little bit with every breath until we reach a new equilibrium. So the fundamental problem here is that before our respiratory rate change, we were just barely completing exhalation within our available 3-second expiratory time. And now we're giving the exact same lung the exact same tidal volume with only 2 seconds of expiratory time. Auto-PEEP is something that can happen in any ventilator mode, but it's probably most likely to happen when you're in a volume control mode and when you're increasing the respiratory rate. The best way to prevent auto-PEEP is to watch the expiratory phase of the flow graph and make sure it returns back to 0 on its own before the next breath is triggered. One way to prevent auto-PEEP in this scenario would have been to decrease the I/E ratio at the same time that we increase the respiratory rate. Let's say we increase the respiratory rate to 18 breaths per minute and decrease the I/E ratio to about 1 to 2.3. That would result in an inspiratory time of 1 second and an expiratory time of 2 1/3 seconds, which is just about exactly what's required. And our graph would wind up looking something like this. Flow would be a little bit higher, pulmonary pressure would increase to the same point, just a little faster. Circuit pressure would have been a little bit higher to overcome the resistance for the given higher flow rate, and in the expiratory phase, you would have 2 1/3 seconds to finish expiration. So the lesson here is that you can increase respiratory rate to increase ventilation. It works great, but you need to be careful of auto-PEEP and make sure that your expiratory time after the change is sufficient for full expiration. If it isn't, then decreasing the I/E ratio is one way to try to prevent that issue. When you decrease inspiratory time with a constant tidal volume, peak pressure will increase a little bit because more pressure is needed to overcome resistance at a higher flow rate. But the maximum point of the pulmonary pressure curve, which would be the plateau pressure if you measured it using an inspiratory hold, would not increase because you're delivering the same tidal volume to the same lung. Now, let's look at strategy number 2, which is going to be increasing the tidal volume. As before, the first question is, how much do we need to increase the tidal volume? Our goal is to reduce arterial carbon dioxide partial pressure by 2/3, and right now our tidal volume is 400 milliliters. Let's assume that our dead space volume is 130 milliliters, so our alveolar volume is 270 milliliters. That is the number that we have to increase by a factor of 3/2, the reciprocal of 2/3. So our new alveolar ventilation goal is about 400 milliliters, and when we add the dead space back in, that results in a new tidal volume right around 550 milliliters. So our new ventilator settings will be a new tidal volume of 550 milliliters, a respiratory rate that will remain at 12 breaths per minute. Minute ventilation is going to work out to 6.6 liters per minute, and the I/E ratio, inspiratory time, and expiratory time will remain the same. We'll march these inspiratory and expiratory times out on the horizontal axis of the volume flow graph. We'll start a new inspiration. The new tidal volume means that the area under the flow time curve is 550 milliliters. The pulmonary pressure will increase in proportion to the tidal volume because the compliance relationship between pulmonary pressure and volume distension is the same. Flow rate is a little bit higher, so the circuit pressure delta over pulmonary pressure will also be a little bit higher. As we cycle to expiration, we drop back down to PEEP. Pulmonary pressure will start higher and then decrease, and it looks like we'll just complete expiration in the expiratory time, so we escape auto-PEEP. Expiratory flow, driven by a higher delta between pulmonary pressure and PEEP, will be a little bit higher, and then the exact same thing happens on the next breath. So we've successfully increased our ventilation, which will decrease our alveolar and arterial carbon dioxide partial pressure. We've just barely squeaked by without causing auto-PEEP, and the real big side effect that we caused here is that we increased the plateau pressure, the highest value that the pulmonary pressure reaches. So this is complication or trade-off number 2 for today. We've increased our plateau pressure. And you can expect to increase your plateau pressure anytime that you increase tidal volume just because of the compliance relationship. We know that delta P is 1 over compliance times delta V, so if you increase the volume pumped into the lung, you'll also increase your pulmonary pressure. So now we've seen the 2 trade-offs that you're trying to balance when you're increasing ventilation. As you increase your respiratory rate and tidal volume, your goal is to hit your target minute ventilation while avoiding both auto-PEEP that will result from insufficient expiration time and the increase in pulmonary pressures that will result from high tidal volumes. It's also important to remember that increasing respiratory rate and increasing tidal volume are multiplicative, so often you'll find that it's easiest to increase both respiratory rate and tidal volume a little bit to hit your minute ventilation goal rather than relying on a larger change in just one or the other. Now, let's shift gears and look at the same problem in pressure control mode. So this is the same patient, intubated for airway protection, with an arterial carbon dioxide partial pressure of 60 millimeters of mercury, which you'd like to lower to 40 millimeters of mercury. And I've tried to keep the settings here very similar. The patient is being ventilated in pressure control mode at a respiratory rate of 12 breaths per minute. The PEEP is 5 millimeters of mercury, and, by convention, when we set a ventilator in pressure control mode, the inspiratory pressure we set is what is added to the PEEP during inspiration. So here, our PEEP is 5 centimeters of water, the inspiratory pressure is set at 10 centimeters of water, which means that our peak pressure will be 15 centimeters of water. People will refer to this setting as pressure control 10 over 5, meaning that the inspiratory pressure is 10 centimeters of water and that PEEP is 5 centimeters of water for a total peak circuit pressure of 15 centimeters of water. This just so happens to work out to a tidal volume of 400 milliliters based on my completely made-up compliance. So let's look at how we can get our PaCO2 down from 60 millimeters of mercury to 40 millimeters of mercury. We'll start with strategy number 1 again, which is to increase our respiratory rate. Just like before, we'll set our respiratory rate to 18 breaths per minute. And just like before, we're going to leave our I/E ratio the same at 1 to 1.5. And, just like before, that means the inspiratory and expiratory times will be 1 1/3 seconds and 2 seconds respectively. Let's go ahead and draw what this will look like by marking out the inspiratory and expiratory times on the pressure time graph horizontal axis. We know exactly what the ventilator will do with the circuit pressure in pressure control mode. During the inspiratory phase, the circuit pressure will be up at the inspiratory pressure, and during expiration, it will be down at PEEP. So what is the pulmonary pressure going to do? Well, the pulmonary pressure is going to do exactly the same thing for the first 1 1/3 second inspiratory time as it was doing on the left-hand side of the screen before our respiratory rate change. Your lung has no idea how long your inspiration will last, it just responds to the pressure it sees. And then on expiration, pulmonary pressure, of course, returns to PEEP. Just as pulmonary pressure follows the same trajectory for the first 1 1/3 second of the pre-adjustment patient on the left side of the screen, so too does inspiratory flow. Flow will start up at the same point as it did before, and will follow the same trajectory down. But then, when the ventilator cycles to expiration, exhalation starts immediately, so we haven't completed the full inspiration before cycling to expiration, and this repeats breath after breath. The problem we run into with truncated inspiration comes down to tidal volume. Before our respiratory rate change, our tidal volume was 400 milliliters, but our new tidal volume is only 300 milliliters. And again, that's because in pressure control mode, you don't set and the ventilator doesn't guarantee a tidal volume. This inspiration was delivered at the programmed inspiratory pressure, but with a shorter inspiratory time, tidal volume is lower. So with a tidal volume of 300 milliliters, our minute ventilation is 5.4 liters per minute. So we've not increased our minute ventilation much, and if you were to do the math to take dead space into account, you'll find that the new alveolar ventilation has actually decreased by about 5%. So you would expect this change to increase the arterial carbon dioxide partial pressure, which is the opposite of our goal. So this is complication or trade-off number 3, insufficient inspiration. Unlike auto-PEEP, this isn't directly harmful to the patient. It doesn't build up pressure or disturb subsequent breaths. You don't need to reach zero flow on inspiration the same way you do with expiration. But if you don't reach zero flow on inspiration, any further increase in respiratory rate is going to decrease tidal volume in pressure control mode. Now, let's look at strategy number 2, which is to increase inspiratory pressure. So this time, we'll leave all of the timing parameters the same. We'll just increase the inspiratory pressure to 15 centimeters of water over our baseline PEEP. So this would be pressure control at 15/5 with a peak pressure of 20 centimeters of water. Our pulmonary pressure will rise a little bit faster because now we'll have a higher flow rate. We can draw that higher flow rate based on the difference between circuit and pulmonary pressures. We'll have a truncated inspiration here, but you can tell that the tidal volume is still increased significantly. The same thing repeats again for the next breath. So how do our numbers look? Respiratory rate is still 12 breaths per minute. I/E ratio is still 1 to 1.5. Inspiratory time and expiratory time remain the same. And the tidal volume, there's no easy way to calculate. In real life, you would try different pressures and let the ventilator tell you the resulting tidal volumes. But for our purposes, we'll count boxes based on my estimated graph shapes, and we have 1, 2, 3, 4, 5, 6, 700-ish milliliters, probably a bit more than we need. That gives us a minute ventilation of 8.4 liters per minute, and if you take dead space into account, we've increased alveolar ventilation by 110%. That's a little bit too much. We'll have a PaCO2 just under 30 millimeters of mercury. So in reality, you would see that new tidal volume and turn the inspiratory pressure back down a little. The lesson here is that in real life, the tidal volume change for a given inspiratory pressure change is a little bit unpredictable. Often it'll be a fair bit higher or lower than you think it will be. Generally, you have a goal tidal volume in mind and adjust the inspiratory pressure little by little to try to hit that tidal volume. Or you use an advanced mode like pressure-regulated volume control that does that iteration for you. To sum up, today we looked at examples of responding to hypoventilation with hypercarbia by increasing the respiratory rate, tidal volume, and/or inspiratory pressure. And just as importantly, we looked at a few trade-offs that we need to watch out for as we make these changes. Insufficient expiration, or auto-PEEP, is a risk, especially when increasing your respiratory rate in volume control modes. You can try to prevent this by decreasing your IDE ratio, or, equivalently, increasing your expiratory time. And you monitor for this by making sure that the expiratory flow curve reaches zero before the next breath is triggered. Increasing plateau pressure is going to happen when you increase your tidal volume in a volume control mode. In most circumstances, you're trying to keep plateau pressure under 30 or 40 centimeters of water, depending on the patient and the situation. The risk of high plateau pressure is lung injury, which we'll talk about a little bit more next time and really get into when we talk about ARDS. The only way to get around this is by lowering tidal volume or PEEP, so it really is just a trade-off. And finally, we talked about truncated inspiration, which can happen in pressure control modes when you increase respiratory rate or decrease the IDE ratio. This isn't directly harmful, but can keep you from hitting your minute ventilation goal. You can prevent this by decreasing the respiratory rate or increasing the IDE ratio or inspiratory time. Hopefully you're starting to feel a little bit more comfortable with the actual nuts and bolts of adjusting a ventilator to optimize ventilation. Next time, we're going to talk about optimizing oxygenation. Thank you so much for your attention. I'll see you next time.